All right, here we are. So thank you again. Welcome, everyone. We want to get started and be respectful of everyone's time, especially our presenters who are all over the country right now. And they've taken the time out this evening to join Crescent Foundation and the Minority Nurse Educators of Chester County for this wonderful series of Stay Informed, Sickle Cell Disease Across the Lifespan. And we'll be sharing a plethora of knowledge this evening with you all. We hope you all enjoy. Give us feedback at the end. Please, if you have any comments or questions, put them in the chat box, but save them to the end during our Q&A session. And please remain on mute throughout the presentations. And now I'm going to turn it over to Abigail McNeil from the Minority Nurse Educators of Chester County.
Thank you. Thank you so much, Tahirah. Welcome everyone to our presentation this evening. We are really excited and just honored and appreciative of Crescent Foundation for having this program with us tonight. Sickle cell is such an important topic, and I think it's one of those topics that does not get the recognition that it needs and that it deserves. So we are so excited about this opportunity. I am a nurse of many years now, and I can say that I'm really excited about what I'm going to hear tonight, because I think I've actually cared for maybe one sickle cell patient in my nursing career of over 20-some years now. So I'm excited about the opportunity to learn and to obtain more information when it comes to sickle cell. Again, I am the president of the Minority Nurse Educators of Chester County, where we provide education services and resources to the community, and specifically in the Coatesville area. So I just think what a more important time to do that than now, since we've recently lost our healthcare system. So we are happy to be able to share this with the community, and I hope that those that are here will gain as much knowledge as I intend to. I want to say thank you again to Crescent Foundation for having this program with us tonight. We're really appreciative and honored that you accepted our invitation. And then also I wanted to say thank you to all of you that are attending tonight and taking your time out to actually learn more of how to treat individuals that are diagnosed with sickle cell or sickle cell trait. So I also want to thank Chad from Penn Medicine for helping us. Chad is from Penn Medicine, Chester County, the Community Education Department. So thank you for helping us put this program together this evening. So now I'm going to turn this back over to Tahirah.
Thank you, Abigail. So we're going to jump right into it with our provider team. We have Dr. Kim Smith Whitley. She was the former director of Children's Hospital of Philadelphia Sickle Cell Comprehensive Center. She now is with GBT, Global Blood Therapeutics, and I'll let her tell more about herself. And then right up after her, we'll have Dr. Farzana Sayani, who's the director of the Sickle Cell Comprehensive Center at the Hospital of University of Pennsylvania. And you all, I think Dr. Smith Whitley, you have the ability to share your screen now.
Thank you, Tahirah.
You're welcome.
Good evening, everyone. I'm Kim Smith Whitley. I am the head of research and development at Global Blood Therapeutics, a company that focuses on improving the lives of those living with sickle cell disease through disease-modifying therapies. I'm going to speak with you this evening about the pathophysiology of sickle cell disease, really also focusing on why we think individuals with sickle cell disease have pain, and then spend some time talking about sickle cell trait in the athlete. I know that there's going to be a deep discussion about healthcare. Dr. Sayani is going to follow this up by talking about therapies. And then you're going to hear later from Renee Cecil about genetics and from Peg Crowley about the management of pain. But this is just to set the background. This cartoon on the right shows healthy red blood cells. You can see these round shapes, donut shaped, and how they should flow smoothly through blood vessels. When you look at the cross section of the red cell, it shows normal hemoglobin. And remember that hemoglobin is the protein that carries oxygen to and from the tissues. I don't need to explain that in more detail to this group. What is interesting is that a single gene mutation can cause changes in that hemoglobin that then lead to stacking or polymerization of sickle hemoglobin, leading to rod formations within the red cells, changing the conformation or shape of those red cells, making it very difficult to navigate blood vessels, particularly small blood vessels. And that process of blockage of the blood vessels on the lower panel here in panel B shows vasoocclusion. One of the things that is very concerning to many of us is in the early 60s, we only had a model of the underlying pathophysiology of sickle cell disease that said that the shape happened without really understanding the polymerization process, things that lead to the polymerization, and then the impact of or the outcome of that sickle hemoglobin polymerization. This understanding, thankfully, has evolved over the 70s and the 80s, and really culminating in a very interesting aspect in the early 2000s about the concept of the consequences of hemolysis or early cell death, red cell death, as a consequence of having red cells predominantly containing sickle hemoglobin. So what do I mean by that? Well, we know that in certain conditions, the polymerization or stacking of the sickle hemoglobin will be accelerated. And we know when the red cell is dehydrated and the concentration of hemoglobin increases within the red cell, that can predispose. Changes in pH can predispose to increased polymerization and sickling. But it's just recently that we've been able to understand mechanisms of how to prevent that sickling from happening. And so in the early 90s, there was a medication, hydroxyurea, that was shown in models to increase fetal hemoglobin. And I'm sure Dr. Siani will discuss that more. But we realized that the more fetal hemoglobin within that red cell, the less that red cells, that hemoglobin sickling process would occur. And so we started understanding more about the pathophysiology and how to direct therapies to preventing some of the consequences. Let's take a step back though, and go back to the consequences of that red cell sickling or that hemoglobin polymerization. We know that polymerization leads to a shortened red cell lifespan or hemolysis. When that red cell breaks down prematurely, it releases plasma-free heme without any controls, and that can spiral and cause a process leading to chronic inflammation. So individuals living with sickle cell disease at steady state will have increased inflammation, not only as indicated by higher white cell counts, but other markers that show us that they are in a chronically inflamed state. The other thing that having that predominant hemoglobin S or sickle hemoglobin in the cell will do is also change what's happening inside the red cell and on the membrane of the red cell. And we know that cells that contain predominantly sickle hemoglobin are stickier, and that can lead to adhesion. And that then further perpetuates that vasoocclusion. And that can lead to lack of oxygen getting to tissues. If that decrease in oxygen is going to the brain, then obviously that can increase the tendency for stroke, which we see in individuals with the SS type of sickle cell disease. If it's going to a bone or a muscle bed, it can cause pain. And then to the lungs, it can cause acute chest syndrome. And so that is the going theory for the underlying pathophysiology of sickle cell disease and how it leads to complications. We know more now than ever before about the impact of the blood vessel itself, the vascular wall. If you see on the left upper panel here, you see the smooth muscle and you see those endothelial cells lining the blood vessels. And we know that that chronic inflammatory process, that vaso-occlusion, can lead to abnormalities and scarring of the blood vessel wall. And we know that hemolysis leads to a process where you get nitric oxide depletion. And so you can actually get vasomotor changes in the vascular system because of sickle cell disease. So we not only describe sickle cell disease as a red cell condition and a condition of chronic inflammation, but also a condition of vascular dysfunction. We know that this can lead to problems in every organ system. And this you will hear about from Dr. Sayani and from Peg Crowley later. But let's just take a moment to focus on pain. When you get a decrease in perfusion or oxygenation of a muscle or a tissue bed, you can understand how that infarction can lead to a response, a pain response, because of lack of oxygenation. But we really have never done radiologic images that let us fully understand why individuals with sickle cell disease experience pain, because we know that at steady state, they're constantly having that breakdown of red cells. And at steady state, we know that they are constantly having vascular occlusion of small vascular beds. So why is it that at certain times that process accelerates and leads to a painful episode? There are many issues and challenges associated with pain. Individuals with sickle cell disease, because they don't have outward signs of why they would have pain all the time with swelling or inflammation, then they're often not believed that they're having these painful episodes. And that's a challenge that we have constantly needed to address with the stigma associated with sickle cell disease and individuals being accused of being drug seeking. So we know that this is something that is a challenge that we really need to better explain. And now we have mouse models and other ways of trying to better understand what's actually going on so that we can develop therapies to address pain acutely. Right now, I think that that's one of the biggest gaps in care, is that pain treatment is supportive. And we don't have any therapies that can actually stop the pain process and halt vaso-occlusion or that inflammation that causes the pain in individuals with sickle cell. So you'll hear later of how that care is supportive care. And I believe that if we can understand the pathophysiologic mechanisms better, then we'll be able to target with therapies. These are just a few of the references that can get you more information on the pathophysiology of sickle cell disease and pain management. Let's move to sickle cell trait. One of the things that is very important to understand is that every newborn in the United States is tested, but they are tested for hemoglobinopathies. They're tested for sickle cell disease and for thalassemia in order to get them into care. The diagnosis or the identification of individuals with sickle cell trait is just a byproduct of this screening process. And so there's really not been great databases kept for individuals with sickle cell trait so that that information can follow them across the lifespan. And this is something that needs to be addressed by pediatricians who have the opportunity to explain the significance of sickle cell trait at the time of newborn screening follow-up, and also the opportunity to make sure that that information is transitioned from the pediatrician to the adult focused care in individuals with sickle cell trait so it can follow them across the lifespan. Many young women who become pregnant don't understand their risk, whether or not they are sickle cell trait carriers or carriers of other hemoglobinopathy traits. And I think one of the biggest gaps in knowledge is that a woman without sickle cell trait can have a child with sickle cell disease because she may be a carrier of C trait or beta thalassemia trait. So we have to ask ourselves when we're confronted with individuals with sickle cell trait on their chart, do they really understand what sickle cell trait means and what the consequences may be? And we really have learned that there are consequences, although rare, of sickle cell trait that can extend from complications such as renal medullary carcinoma in individuals, more commonly blood in their urine or hematuria. And then in the popular press, an association with exertional rhabdomyolysis and exertional collapse associated with sickle cell trait. And many of you may have heard about these sudden deaths in athletes, predominantly football players training in extreme heat in the off season when they are relatively deconditioned. Those cases were brought forward and screening programs for sickle cell trait were started by the NCAA about a decade or so ago. But we had military data that demonstrated that if we just treated all deconditioned individuals the same by thoughtful hydration and periods of rest, that they would not be exposed to these risks of sudden death. However, the NC2A decided to come up with recommendations to better assess risk. And we know now that exertional rhabdomyolysis is something that individuals with sickle cell trait may experience, particularly when they're doing sprints or in extreme heat at times of being deconditioned. And so the recommendation for the American Society of Hematology and from the NC2A is now thoughtful conditioning with periods of rest and opportunity for hydration in all athletes, particularly those with sickle cell trait. Here's more information on sickle cell trait in the athlete with resources at the CDC. And I hope I have time later on to talk about other opportunities to educate individuals about sickle cell trait and the consequences. And with that, I'll turn it over to Dr. Sayani.
Thank you, Dr. Kim. Dr. Sayani, you have the floor and the ability to share now.
Thank you very much for giving me the opportunity to come and speak to you today. I hope you can see my screen now. Okay, so I'm going to, it is really great to follow Dr. Kim Smith Whitley because she's really laid the foundation for what we're going to talk about. And so I'm going to highlight some of the new advances in the care of individuals with sickle cell disease. So this is the pathophysiology that we just heard about, where the underlying mechanism in the single mutation leads to significant vasoocclusion and hemolysis. But we also, this is a picture of the polymerization, those rods that develop inside the red cell, making them look like sickle cells. That's what. And this is, again, another representation of our understanding of the pathophysiology of sickle cell. As you've heard, it's not just the hemolysis, it's not just the vasoocclusion, but we also have increased inflammation that drives the underlying pathophysiology. We also have increased oxidative stress, and there's also increased adhesion of red cells, white cells, platelets onto the wall of the blood vessel. And all of these in the end result in significant complications that we know of for sickle cell, which is both acute complications and chronic complications. As you've heard, we all, the classic presentation everybody thinks of for sickle cell disease is the acute vasoocclusive episode, which classically presents with pain. However, there are many other acute complications that an individual may present with, all the way from, we can go from the head to the toe, because sickle cell generally affects, I think of it as anywhere where the blood flows. Where the blood flows, we're going to have limited blood flow, and hypoxia, tissue damage, inflammation. So acutely, individuals can present with stroke, infection. They can be retinal complications. It can affect the lungs, where individuals can present with acute chest syndrome, gallstones, liver hepatopathy, sickle hepatopathy. They're at risk of infections because the spleen is is not functional after as early as 5 years of age. Acutely, they can present with kidney papillary necrosis, bone infarctions, osteomyelitis. So there's a whole slew of acute complications that an individual with sickle cell disease can present. What we also know, however, is that more than just the acute pain that classically represents this disease is the chronic complications, the ongoing damage from the hemolysis, from the nitric oxide, from the oxidative stress and damage, from the inflammation. And again, these are highlighted in the green boxes where chronic neurocognitive dysfunction, chronic pulmonary changes, pulmonary hypertension, every organ can be affected as an individual with sickle cell disease gets older. And that stresses the importance of not only the management of acute pain or the management of an acute complication, but also the importance and the need for chronic screening and monitoring for these long-term complications that can be very subtle, but over time, if not monitored for, it can lead to significant complications that do affect survival of individuals with sickle cell. This is a graph that looks at across the lifespan. The bottom is age. And we see from 0 to 50 years of age. We'll see that I focus here on the red line, which is acute complications. We see that in our kids and young adults with sickle cell disease, the number of complications are quite low, and a lot of this is through advances by our pediatric colleagues with vaccinations, with prophylactic antibiotics, with screening for stroke and early intervention. However, there is this period of transition, those young adults, and then well into adulthood, where there is increased number of complications, increased number of multiple organ complications, more frequent hospitalizations, more frequent transfusion requirements. And this is what, as an adult provider, this is really where we need to do so much more, and we need to do better. These are some of the guidelines. I want to stress the importance of comprehensive care for our young adults and adults with sickle cell, just like we have programs in the pediatrics, is the need to screen our adults, not just taking care of them when they present to an emergency room with vaso-occlusive episode, but long-term monitoring. And these are a few of the guidelines from the NHLBI and the ASH, American Society of Hematology, where we talk about monitoring hemoglobins, monitoring liver and kidney function, the annual eye exam, looking for sickle retinopathy, evaluating the heart for pulmonary hypertension and function, also oxygenation, reactive airway disease and pulmonary function tests, the importance of monitoring for early signs of kidney damage with urine protein, the importance of blood pressure monitoring and control, bone health, also looking at the brain for signs of silent stroke. So there's a whole slew of recommendations where we can monitor. In the past, we used to think of sickle cell disease as sort of rescue, last minute, don't know what's going on, it's chaos, the patient's really sick. But as we understand more about the disease, we can begin to look for markers, look for screening tools so that we do pick up complications early. Because now, we're fortunate that we have multiple disease-modifying therapies, and that's the next part that I'm going to talk about shortly. So it's important that when managing an individual with sickle cell disease, that they have a primary care provider who overlooks general medical, takes care of general medical care, which is going to include vaccinations, the annual eye exam, nutrition, blood pressure control, the importance of managing the acute pain, but also chronic pain, which increases as individuals get older. And then, as I've mentioned, screening for and managing acute and chronic complications. Again, this is where the hematologist with expertise in sickle cell disease comes in. And then there are disease-modifying therapies that we'll talk about. And then there's potential for curative therapies as well. So I'm going to focus the next few minutes to go over the disease-modifying therapies. So we've heard about the different ways and the different abnormalities that are contributing to the pathophysiology. And so the first drug that we've had for the longest time is hydroxyurea. Hydroxyurea works in several different ways. It increases fetal hemoglobin. It lowers the white blood cell count, so that can lower the inflammation. It reduces the stickiness of the neutrophils and the reticulocytes. It improves the red blood cell hydration, so they're less likely to sickle. And it also causes these blood vessels to stay dilated and allow for better flow. Hydroxyurea we have the most data with hydroxyurea. It has been shown to reduce painful episodes, reduce the frequency of acute chest syndrome by as high as 50%, reduce the need for blood transfusions and hospital admissions. And we also have long-term data that it reduces mortality, and there's no increased incidence of malignancy compared to the general population. And so now there's good data of starting hydroxyurea in infancy because of the significant benefit. We generally use it in individuals who have severe forms of sickle cell when it comes to adults with, we use hydroxyurea in those with severe forms of sickle cell disease where they have more than 3 pain episodes a year, or they've had 2 or more episodes of acute chest. And we may consider it in other individuals who may have other complications. We generally start hydroxyurea at a low dose, and we titrate it to the maximum tolerated dose. We check the CBC every 4 weeks, and we go up on the dose. We're watching their neutrophils, their hemoglobin, and their platelets, and we monitor their liver enzymes as well. It's generally well tolerated. Patients may have some headache, occasionally some mild nausea or discomfort. Some patients may have some skin changes, some dark nails, and there can be myelosuppression if we are at a high dose. But hydroxyurea is what we have the longest data for. Not only does it raise the hemoglobin, but for individuals with SS, it also reduces pain episodes and acute chest, and therefore is the first line of therapy. L-Glutamine is another drug that was approved in 2017. L-Glutamine is an essential amino acid. We make it in our bodies normally, but in those with sickle cell disease, the stressed red blood cell doesn't make enough of these antioxidants. And L-Glutamine works by reducing that oxidative stress in the red blood cells. And allows, the idea is it allows the red blood cells to live longer. So in a phase 3 study, randomized controlled trial of 230 patients, it reduced the vaso-occlusive episodes from an average of 4 episodes per year to 3 episodes per year. And there was a longer time between the vaso-occlusive episodes. It was also shown to be effective in those on its own or in individuals who are also on hydroxyurea. Comes in an oral powder form, and it's mixed with food or a beverage and taken twice a day. Generally well tolerated. Individuals may get some constipation, some nausea, some occasional headache, and some musculoskeletal pain. It can be given on its own or with hydroxyurea. So we generally consider adding L-Glutamine in those with mild to moderate vaso-occlusive pain who are, despite being on hydroxyurea, or in patients who are continuing to have vaso-occlusive episodes but cannot be on hydroxyurea. So that's one option that is available. There's crizanlizumab. This is a new, was FDA approved in 2019. We heard about the increased adhesion that contributes to pain and the underlying pathophysiology of sickle cell. And what we now know is crizanlizumab, this medication, blocks the binding of sickle cells to a molecule called P-selectin that's on the inside of the blood vessels. And so generally it makes them less sticky. In the SUSTAIN trial, what it did show is that the median rate of vaso-occlusive episodes per year was decreased by 50% in those who were on crizanlizumab. And it was able to reduce vaso-occlusive episodes, even in those individuals who were on hydroxyurea. It's given as an IV infusion, initially every 2 weeks for the first month, and then we give it once a month thereafter. Some side effects, maybe some joint or back pain. There is potential for an infusional reaction that we now have a better understanding of how to manage. There may be some nausea and low-grade fever. It can be used monotherapy, but can also give additional benefit in those who are already on hydroxyurea. Individuals, if they're going to, most individuals will see a benefit after their, after their first or second doses. And so the optimal patient we think of is those with individuals who have vaso-occlusive phenotype, increased vaso-occlusive pain episodes, and we also in those who may not be able to be on hydroxyurea. The question still remains: do individuals have? Can it protect other organs, the kidneys? Can it protect priapism? And we're still waiting to get that data. The last drug that we now have is voxelotor or Oxbryta. This was approved in 2019. And voxelotor binds to hemoglobin within those red blood cells and reduces the polymerization. And in the HOPE trial, which is the phase 3 double-blind randomized trial, we saw on a dose of 1,500 milligrams per day, it was able to raise the hemoglobin in patients. You can see in this graph here, the dark green line here, those on the 15 milligrams, this is their rise in hemoglobin. It happens very quickly within the first 2 to 4 weeks. Those on the voxelotor had a higher hemoglobin rise, a higher hemoglobin response. What does that mean long term? There's data that, there's some data, but we still need more. Will this reduce complications? Will it reduce pain? And we await more information on that. Overall, it's given orally. There's a few common side effects, which are generally mild, may be used in combination. Again, we see that hemoglobin come up. We generally think of voxelotor in those individuals who have more of a hemolysis. They have a lower hemoglobin because, again, the data showed that it can raise the hemoglobin. So that's who we try. So there are lots of options available now for individuals with sickle cell disease. And so again, stressing the importance of a comprehensive sickle cell program, which is a multidisciplinary program. Ideally, we have expertise in caring for adults with sickle cell disease. And at Penn, at the Hospital University of Pennsylvania, we have developed a comprehensive sickle cell program where our goal is to increase patient engagement, to help manage pain, but also other symptoms, to begin to use other disease-modifying therapies so that we can hopefully screen and manage and reduce the long-term complications, and overall provide better health and improve psychosocial well-being. We're working as a multidisciplinary program to really work in the institution, to work to improve inpatient care, emergency room care, working with subspecialists to increase awareness and education and also care for complications of sickle cell. We have an infusion center in a day hospital, and then community engagement as we do. This is our entire team who comes in every day and really does an amazing job to care for these individuals. And with that, I just want to thank you all for giving me the opportunity. I may not be able to stay for question and answer. So if you're able to present any questions in the chat box, I will try and answer them as they come along. Thank you very much.
Dr. Sayani, there are some really good questions in the chat box if you head over there right now.
Perfect. Thank you.
They've already started coming in. But while you're doing that, we'll go on to the next presentation with our social work team. And I believe up first we have Trudy Schum Johnson from the Children's Hospital of Philadelphia. Trudy, are you still on?
Yes, I'm here. I'm just pulling. I'm going to share it in a moment. Okay. Good evening. My name is Trudy Schum Johnson. I am a sickle cell social worker. I'm also program manager of our Comprehensive Sickle Cell Center at Children's Hospital Philadelphia. And I'm really honored to be here today to just share some of the work that we've done to support academic sickle cell disease and academic education. So we have close to 1,000 patients located at 3 sites at Children's Hospital. At our main campus, we serve about 850 individuals with sickle cell disease, ranging from birth through age 22. At our Voorhees site in New Jersey, we have around 130, and at King of Prussia, we have around 20. So in general, we know that the link between school attendance and chronic absenteeism is a very significant link. Out of the 605 million children in the US that are students, there's about 15% of them that miss more than 15 days of school a year, categorizing them in the space of chronic absenteeism. And it's based on several different types of health disparities that we're aware of and we know in our community affect our patients and our families, in addition to the fact that they have this chronic disease. Just to give you an idea of how many students we have with sickle cell disease, the last set of data that the Pennsylvania Department of Health School Health Statistics posted was from the school year of 2017 through 2018. And basically, this shows how many students per county were captured. This does not include parochial and charter schools and some of the independent schools. But as you can see, in Chester County, there were around 19 students that were captured and identified as individuals with sickle cell disease. And in Philadelphia County, we had about 1,297 individuals that needed support in the school system. So why collaboration matters? It matters because we know that in order to address the system level inequities, we have to consider the importance of a multidisciplinary approach. And part of what that looks like is not just the healthcare providers, but also your school teachers, your athletic departments, guidance counselors, and school administrators. Our school health services in the schools are equally as important in ensuring that our students not only stay on task and are able to meet all of their academic goals, but also then it's our job to arm you with what you need to best serve our students and the families that support them. So in 2020, the National Academies of Sciences, Engineering, and Medicine developed the respective report, Sickle Cell Disease, on sickle cell disease. And what it called for was for the US Department of Education to partner with schools, state school boards, local boards, regional boards, to develop material that supported the individual with sickle cell disease. So we're fortunate in that at Children's Hospital, this was something that historically has been something that's always been on our minds. We've always engaged historically with our school systems and tried to create tools that actually met the needs of our students in the schools. And I'll share a little bit about what that looks like historically for us. But this is the latest version of what we provide our families, provide schools. This was developed with just before the pandemic. It is due for a bit of a revision, but we do find that it's a helpful tool for our school systems at every level, and I'll go through that a bit. So in this handbook, we created templates that support school health services, early childhood education providers, teachers and substitute teachers, high school and guidance counselors, athletic departments, before and after care, summer camps, We have a template on daily water consumption, fostering emotional well-being, and also supporting a student who has had a stroke. This is an example of our 504 and IEP plan specific to individuals with sickle cell disease. This is a tool that we use to educate our families about the difference between the two and so that they can make an informed decision if this is what they want to ensure that their child has, just to support their child's academic needs. What we've seen and what we've learned is that it's helped support communication between families and education, academic institutions. I would say it's very rare for us to have to get involved, just because it has opened a level of dialogue for caregivers, students, and their academic teams to create plans that actually foster wellness. So the three types of letters the three topics of letters that we provide are our early childhood education, so for our daycares and so forth, pre-K programs. We also have a letter template for our elementary, middle school, and high school that address either 504s or IEPs. And then we supplement it also with an athletic letter. Our nurses also will complete medication forms for school nurses as well. And we've been involved in 504 planning meetings and have been available to families as well, families and education providers as needed. Our families complete release of information forms, and they also complete FERPAs so that we can have that communication throughout the school year. We also encourage 504 planning as well for our college students and those who are in specific vocational trade schools. And I'll go into that a bit more in a moment. So in general, these are the two main topics that we address when you look at our 504 planning letters. We provide clinical recommendations, and there's a section for educational recommendations. Under the clinical recommendations, you can expect guidance around prompt medical attention, painful episodes, hydration, increased fatigue, frequent absences, academic performance, and psychosocial issues. And then under educational recommendations, we have accommodation language that coincides with our clinical recommendations, but specifically around attendance and instructional accommodations, test procedures, communication accommodations, and environmental and setting accommodations as well. We developed a tip sheet for the college and career-bound student. This specific tip sheet is something that we give as a tool in clinic to our sophomore, junior, seniors in high school. It's designed to help them think through, if they're going to college, some of the things that we'd like them to consider as well as when they're making their choices. We have a guidance counselor version of this as well that also exists on our website. And for our college-age students, one of our biggest things that we push is communication with the respective Office of Disabilities, and as well as student health services. We want to make sure that they're receiving all of the recommendations, and there's a plan to support them at all costs based off of the 504 request letter that we submit to the Office of Disability. We teach our students about the importance of the what's outlined in the letter, and then we help support them with addressing the respective documentation that might be supplemental documentation at the schools. We also encourage them to connect with their state's Office of Vocational Rehab, just to ensure that there are additional advocacy venues for them. And if there's any scholarship or resources that they can access depending on the major that they choose, that they have that advantage as well. We also, we also have created education resources for caregivers, and this lives independently on CHOP's website. It's also linked to our sickle cell school outreach website. This particular education resource guide was created, but it was also guided by feedback by our sickle cell educational work group, but it serves as a resource for any caregiver who has a child with a chronic condition. It's really a hub of educational resources that help with remote learning, skill instruction, and special education resources as well. And just, I'm hoping that we'll be able to send these slides out to you all, but these are the two links where you could reach, take a look at our sickle cell school outreach information, but then also to the education resources for caregivers to help support their children. And just in general, if you need to reach our school outreach team, this is our number and our email address, and we're happy to support any request that comes through and get as creative as we need to be to help support the students that we serve. Thank you and have a great evening. And with that, I'll defer to my colleague, Stephanie Devon.
Good evening, everyone. Let me just share my screen. I'm sorry, let's see. Can everyone see it? Okay.
Yep.
Okay, can you see it?
Yes, we can.
Okay, great. Good evening. My name is Stephanie Devon. I am one of the social workers at Penn's Comprehensive Sickle Cell Program. And tonight I'm just going to do a little overview centered on mental health and the partnerships that we have with the community-based organizations and the supports and services that they provide, not only to the patients within our program, but alongside the pediatric patients that transition from CHOP to HUP. For their adult care and managing their sickle cell. So first, I wanted to kind of give an introduction to the impact of mental health and sickle cell disease. Patients often suffer from significant psychological distress due to the complications of sickle cell disease. Their pain can represent a non-specific sign of a mental health disorder. Some of the most common psychiatric comorbidities are depression, anxiety disorders, sleep disorders, and bipolar disorder. Another major concern is often opioid use disorder, as many patients are on long-term opioid therapy to reduce chronic pain. Poor mental health can also worsen symptoms of sickle cell disease, making it more difficult to cope. Stress in particular is a common trigger of painful episodes. Some research studies have found a link between sickle cell disease and depression. There was a study that supported that in 2019, out of 73,225 patients with sickle cell that were hospitalized, 8% had depression. Depression was found to be more common in adults from the ages of 30 to 50 years old and affected females more than males. Anxiety is another mental health condition that impacts individuals who have sickle cell. Patients are presented with stressors that are usually associated with the unknown. When it comes to sickle cell disease, feelings of isolation, worries centered around medical care costs and treatment across the healthcare system. So again, just to kind of elaborate a little bit more on some of those stressors that impact patients, it sometimes is initiated from the onset. So when they're just finding out, and then there's concerns with adherence to treatment plans, which can cause stress. Because you kind of have to structure your life in a certain way and making sure that you're following through with those treatment plans, or adherence. For example, when you go into the ED, you have to advocate in regards to, the treatment plan that you have put in place with your hematologist and making sure that ER provider is following through with that. The stigmas that are associated with patients and individuals that are living with sickle cell disease, you know, they're coming in and they're being judged and being told, well, you don't look like you're in pain, or the stigma of them possibly drug seeking. So stigmas alone can contribute to stress and a constant fight that patients and individuals have to deal with, you know, when expressing that they're not feeling well. Lack of supports is also another stressor, and psychosocial factors. So when we meet with our patients and PENS program, we like to do a complete biopsychosocial assessment, and included in that assessment, we always like to assess for suicide risk. Stress is a factor that can contribute to that. So we always like to assess for it. We'll ask patients if there's any current or history of suicidal ideation, homicidal ideation. We like to ask them if there's any family history of depression, if there's any current or recent history of inpatient hospitalizations, outpatient treatment. We like to kind of gauge what that support looks like for the patients. We try to gauge if they're interested in any type of mental health connections to, you know, to kind of help manage and provide some, to eliminate any stressors that they may be feeling. If we do have patients that may have expressed history, or they may have expressed that they may feel that way, but it doesn't come across as if it's acute, it doesn't come across as if it's acute, then we may develop a safety plan. Just have a discussion with them to see what that looks like when they do feel that way, or what did they do when they felt as if they wanted to harm themselves. We like to also explore the environmental factors and supports that they have in their life. We all know, just as human beings, having, you know, environmental support, family, friends, something that we lean to, that we find supportive, and we view it as something positive in our lives, that can also lead to help eliminating the amount of stress that we may experience. What we also do is we like to refer to commonly used mental health resources. So we'll, you know, make patients aware of the local mobile crisis services that exist here in Philadelphia. We provide information pertaining to the suicide hotline. There's been many a times when I've had discussions and worked with patients and helping them get connected to therapeutic support. So contacting their insurance providers. I don't know, that's my watch. I'm so sorry. Contacting their insurance companies to see who's in network and what therapy services that we can get them connected to. And lastly, we reach out to any other community-based organizations or services that could also help to get them connected with mental health treatment. Which now is my segue into our partnerships with community-based organizations. We do work with various community-based organizations throughout the city, and we partner with them across the area, and they provide support and services to individuals with sickle cell disease. Crescent Foundation is one of the CBOs that our program partners with closely, and they're really great with helping us help the patients and addressing the needs to target any social determinants of health that impact our patients. So these are just some examples of some of the themes of supportive needs that our patients may have that we have made referrals to Crescent to. That this includes housing, care coordination services. So that could be if it's a complex patient and they have other medical conditions, then they have a hard time keeping appointments, or they have a hard time managing medication and things like that. So care coordination referrals are something that we commonly see. Health and medical insurance. We know that sometimes, especially for our CHOP patients that are transitioning to us, you know, this is a new world to them. So sometimes they're now starting to get on their own insurance and not really sure how to navigate that system because it can be complicated at times. So we may refer out to a community-based organization for support in regards to that. Rent and mortgage assistance. I usually see this on both sides. I see this on the sides from our transition patients and patients that come to our program. So we'll try to get them connected to that. again, transition. Sometimes, again, the patients that are coming from CHOP, they're so used to, this is a place that they've been going to since they were young. So now that they are transitioning to a world that requires them to be a little bit more independent, is nothing wrong with having that additional support. And through Crescent, there's a community health worker who continues to work with these patients all the way, up until they transition. And we collaborate with that community health worker as well to see how we can continue to provide the best support. Utility issues is another common supportive need, transportation and food insecurity. So these are just, again, when we look at these type of things, these are things and psychosocial factors that really could cause stress in a person's life. So being as though our partnership with these community organizations like Crescent exists, again, our goal is to provide comprehensive care and help to eliminate any stressors so that, you can continue to move forward and maintain while living with sickle cell disease. The impact of working with community-based organizations and our patients being able to utilize them is it contributes to the continuity of care. Collaborative efforts between the healthcare provider and the CBOs show the patients that there's a sincere interest in their management and their healthcare. Commitment to quality of medical care and quality of life, and a supportive resource that helps to address psychosocial issues that can lead to limited stressors. Again, some of our collaborative efforts between social work through PENS program and the CBOs is some of the most common referrals we submit, again, are centered around utility management and transportation. Referral requests from our patients who have transitioned from pediatric to adult care typically range from transportation, housing, and educational support, which coincides with what Trudy was just discussing. So we try to keep that continuity when it comes to them transitioning, because we definitely don't want to interrupt, their educational process. And then these partnerships also contribute to the improvement of health equity in our patients, and it serves as a supportive factor when addressing social determinants of health. And that is it. Any questions for me?
Thank you, Stephanie.
You're welcome.
So there's some questions in the chat box. If you feel free, if you want to take those, or we could just wait until the Q&A portion when we'll open up the floor to have people ask questions directly to you. And we are going to move on to our nurses. And I think, is Nurse Renee going first or Nurse Peg?
Yeah, I'm going first.
Okay, so I'll share your presentation. There we go. Nurse Renee?
Okay,
All
great.
right.
Thank you. Good evening, everyone. As you know, my name is Renee Cecil. I was the nurse coordinator for the Comprehensive Sickle Cell Center at the Children's Hospital of Philadelphia for 31 years. I retired in December of 2020. I'm currently now retired and working as a mental health counselor. Initially, I thought I was going to be talking about the educational program at CHOP that we did, but then I was requested to talk more about some of the misconceptions that are out there, and also about some of the reasons, the things that affect pain in individuals with sickle cell disease. But just to reinforce, as a nurse working with children with sickle cell disease, my primary function was to do sickle cell education with families and their children, so that they would be able to manage their child's care most effectively. So all of the different complications you heard about earlier are all things that, as the nurse coordinator or nurse educator, it was my responsibility, and whoever, works in sickle cell disease, to educate families about the various things. So some of the misconceptions about sickle cell disease. There's a lot of them out there, and I'm sure I haven't covered them all. But one of the ones we used to hear a lot is that people thought that sickle cell disease is contagious. So you would have a kid who was getting ready to get a job at McDonald's, and he might have some jaundice, and right away they think that he has something that they can catch. And he sometimes had to get information from us, letters and whatnot, to let people know, no, you can't catch sickle cell disease just by being around someone with sickle cell disease. Sickle cell disease is a group of inherited red blood cell disorders that you get that are transmitted from parent to child. Another one is that only Black people get sickle cell disease. Although most people we know who have sickle cell disease here in the United States are people of African descent. Not everyone with sickle cell disease is of African descent. There are people from the Mediterranean region, the Middle East, East India, the Caribbean islands, and Central and South America. At CHOP, there were patients who were Greek, Italian, from Saudi Arabia, East Indians. So there was quite a diverse population at CHOP who suffer with sickle cell disease. Sickle cell trait is a mild form of sickle cell disease. That is false. Sickle cell trait is not a mild form of sickle cell disease. Individuals with sickle cell trait have inherited only one abnormal gene. Individuals with sickle cell disease have inherited 2 abnormal genes. People with sickle cell trait do not experience symptoms of sickle cell disease under normal circumstances. And Dr. Smith Whitley gave a great presentation on when individuals with sickle cell trait might show some symptoms. Next, please. Individuals with sickle cell disease cannot fly in a plane. That is also untrue. They can fly in airplanes. They should only fly in commercial airlines because commercial airlines are pressurized. Flying in a non-pressurized airplane can cause problems. Next, please. Individuals with sickle cell disease are immune to malaria. That is also false. People who have sickle cell disease can become infected with malaria just like anyone else. In fact, it's seen a lot in areas that have a lot of malaria, that people with sickle cell disease can have very poor outcomes if they get it. And there are some literature out there that says that people with sickle cell trait may be provided with some protection against malaria, but in any rate, whichever you have, sickle cell trait or sickle cell disease, if you're going to an area that has malaria, you should always get your anti-malarial vaccines. Okay, now some stuff about sickle cell disease and pain. Both physicians showed you how vaso-occlusion happens. And the fact that sickle cells, when red blood cells sickle, they can become stuck and block small blood vessels. Pain is one of the most common complications that we see in sickle cell disease. Pain can occur in any part of the body. And some pain does not always require hospitalization. In the years I was at CHOP, you notice that when a child finally comes into the hospital, it's usually because they've exhausted all of their means of pain control at home. Most people do not want to come into the hospital. Pain can be mild to severe. It can vary in intensity and its frequency, and it's unpredictable. The fact that pain is so unpredictable can become a major issue with people. You plan a vacation, you plan to go to your prom, you plan a lot of different things, and you're unable to go because boom, you have sickle cell pain. You can also have fever. when you have sickle cell pain. There are types of pain. It can be acute, where it lasts for a short period of time, or it can be chronic, ongoing, lasting more than 6 months. Or it can be, you can have both, because if you have chronic pain, that doesn't mean that you can't have an acute episode at a different location from where you're having your chronic pain. Okay. Some of the triggers for sickle cell pain: cold temperatures is a big one. Thermoregulation causes vasoconstriction. So that means that it makes it harder for the blood to flow properly. What can you do about that? Dress warm in layers. We always encourage parents to make sure that they dress their children appropriate for the weather that's going on. Because if you dress them too hot, then you run into them perspiring a lot, and then that could be dehydration. But particularly in cold temperatures, you want to make sure that children are dressed well. Limit the time of exposure to cold weather, air conditioning, that sort of thing. If you're going to be going swimming, you should do some warm-up exercises before swimming. When we had sickle cell camp, we used to have the kids do jumping jacks before they actually got into the pool. And then once they got out of the pool, they dry off immediately so that they don't get chilled. They should avoid swimming in cold pools also. Dehydration, red blood cells can clump together because they're dehydrated, and that increases the chances of experiencing pain. Some of the causes of dehydration are consuming alcohol, excessive sweating, diarrhea and vomiting, fever. Caffeine can also be a problem. I didn't put that on there, but caffeine can also be a problem. Next, please. Okay, so what can a person do? They should drink plenty of fluids. As Trudy was saying, for the children's booklet that they have for schools, they have a whole section on fluids and how to make sure the kids get fluids. And for adults, you just know you need to drink. So you should always have water or juices available to you. Increase fluid intakes during illnesses and exercise. Limit your alcohol intake and avoid smoking. Stephanie gave a wonderful presentation on mental stress. So just to say that mental stress decreases microvascular blood flow, so that you want to make sure that people get referred as properly. For us, they're usually seen as depression and anxiety due to unpredictable and recurring pain, fear of what the future holds, and all the other things that Stephanie outlined so well. Okay. Families and patients should be encouraged to discuss their feelings and concerns with their healthcare team, and be referred to mental health professionals for evaluation for counseling and possibly medication. Infection can also be a cause of pain. It induces multiple physiological changes, which increase the risk of sickling. Individuals with sickle cell disease should seek prompt medical care for temperatures greater than or equal to 101 degrees Fahrenheit. They should consult healthcare providers when experiencing nausea, vomiting, diarrhea, or respiratory symptoms. Children with sickle cell disease should start prophylactic penicillin by 3 months of age, and individuals with sickle cell disease should receive all of the recommended vaccines. Thank you very much. And I'll pass it over to Peg Crowley.
Nurse Peg, do you need me to share your presentation? I think you're still muted. There you go. Nurse Peg?
And here I am.
All right.
And
Do you
I'll
need
see
to
if I
share your?
can do the share thing and get my slides up here.
There you go.
Okay. So I will start. My name's Peg Crowley, and I'm actually a nurse practitioner and cared for adults with sickle cell disease for the last 14 years at Pennsylvania Hospital down at 8th and Spruce, who also have a sickle cell program. And I want to talk about adults that deal with pain issues. You've heard a lot about pain. They're also confronted with end-stage organ damage, pulmonary hypertension, kidney failure that starts to be seen in adults. And it's important to note that the majority of patients are young adults. Most of my patients were in their 20s and 30s. We've come a long way with extending the life expectancy of sickle cell. But as you can see, it's been kind of slowly progressing. When we finally got the National Sickle Cell Act and people started having the centers that gave penicillin, hydroxyurea, transfusions for stroke, we saw an increased life expectancy for our patients. So more adults. Back here in the 1920s was few adults. We've continued to keep seeing an increase in the life expectancies. But again, you can still see, this is from 2000, but I rechecked most recently, it's still, their life expectancy is about 22 years less than average Americans. So hopefully some of these new findings that we're seeing in new drugs for sickle cell will really help continue to improve, as well as some of the genetic things going on. Another thing to note about sickle cell patients is their quality of life. And this PISA study that's referred to even in today, even though it was done in 2005, noted poor health quality of life for sickle cell patients. Their health quality of life was equal to or poorer than patients with other significant chronic conditions like dialysis. So I think when we as nurses care for patients, we need to assume that their quality of life is seriously affected. Just as I think Renee mentioned, you plan a vacation and you can't go, as well as many other interferences with your life. So pain in adults. They experience the sickle cell crisis, as we've heard about, but they do develop chronic pain. So per the PISA study, about 55% of patients experience pain on 50% of the days and 29% every day. Most pain is handled at home with increase in fluids, Epsom salt baths, rest, pain medication, both over the counter and prescribed. Opioids indeed are used to treat crisis and are also used at home as needed to manage pain. I'll also mention that marijuana is also used, and sickle cell anemia does qualify for medical marijuana. And the main thing I heard from patients using this was that it really does help improve your sort of mental health, sort of let you relax while you get through the crisis. I want to make an important statement that sickle cell patients are not part of the opioid epidemic. There was no increase in opioid-related mortality for sickle cell patients from 2017 to 2019 when we were hearing about this rapid increase in deaths from overdoses. There was no increase in the amount of opioids prescribed. They may be a high amount, but they did not increase. And in general, sickle cell patients are not overdosing. And I think it's important to recognize this with all of the focus we've all been put under in concern about opioids. So what about pain management during a crisis? The important thing is that it requires quick, effective pain relief with opioids. And most places, I know both the Hospital University of Pennsylvania and Pennsylvania Hospital, as well as over at Jefferson, a plan of care should be developed by the sickle cell care provider and have it be available to the hospital staff. That's pretty easily done nowadays when we have computerized information. When I first started, it was all in a big binder down at the emergency room. Indeed, in addition, we have a plan, but we also have to include our patients in that plan, both of those of us that develop the plans as those carrying it out. And we as nurses need to be an advocate for addressing adequate pain control in these times when there is concern about overuse of drugs always. Because it is equally important for us to advocate for more medication when it's needed, as well as to reduce the medication as we see that the dose is no longer needed. What about those patients that come in without a plan? They are more difficult to manage, but they will require IV opioids, and you can always start low, but advance as needed in consideration of the home opioids or previous pain crisis. And we as nurses need to monitor all our sickle cell patients, because you're the one at the bedside. And you can note the sedation if it's too much. You can note fever, and this would be an indicative of some kind of infection. You can note that low pulse ox, the patient that you go into the room and they were at 2 liters and now they're at 3, and you're thinking of putting up to 4. You start worrying about acute chest. We monitor for confusion that can be sepsis or some stroke. And also we continue to monitor for uncontrolled pain. That said, I did not come prepared to give item by item description of pain management tools. We do use more and more of the PCAs, and we do consider giving other medications along with the typical narcotics. But what I wanted to focus on right now is something that I observed time and time again, and that is the outstanding resilience of sickle cell patients. Sickle cell patients deal with crisis and complications, chronic and acute pain, and continue to have a life. They continue to raise their children. Every mom has plan A, I'm home to greet the kids, and plan B, where should you go if I'm not home? Who picks you up from school? Whatever. And that would go for fathers raising their children also. Need to continue to go to school, even though, as Renee noted, and I've noted with adolescents, they miss about 12% of their school days. College is still not impossible. I think I had 2 of my patients graduate as nurses, and one's in an NP program now, and multiple other positions. They continue to hold jobs. I did see one of the questions that was asked in the chat is what kind of jobs are recommended, and sickle cell patients kind of make their own decision, obviously, on that. But I do note that often they will choose jobs that give them some flexibility. Sales, house, realtors, positions where there's flexibility is very helpful. Even those nurses have chosen areas where it's not necessarily a 9-to-5 job every day, 5 days a week. And they do continue to hold jobs, and they do continue to perform. And one of my patients that I'll share a little bit with you about that really makes me take my hat off and recognize this resilience is the patient who's a rapper. And he was in the hospital with a hemoglobin of 3.5, which occurred after we gave him transfusions, and he had a reaction and an infected hip and just very, very seriously ill. And got through all of that, got on Oxbryta, hemoglobin came back up, got stabilized, and is outperforming in Atlanta, and called me to tell me that he had his 100,000th hit on, I think, YouTube. So I do think it's important that we recognize that through all of this, these are people that have a lot to offer us. And I retired about 3 months ago from my job. And was lucky enough to have many of my patients come and talk to me when I was leaving, and with all of my skills, the main thing patients told me over and over again is that I listened to them. So patients have identified being heard as very important to their care and something often overlooked. They sometimes feel ignored, yet I can tell you from experience that the patient can tell you that the pain in his chest is different from his usual crisis. Patients can also help us identify obstacles to care. A patient of mine that was thought to be overusing the emergency room and addicted to IV drugs, when we finally developed a good relationship, we figured out part of the problem was just not having enough support, kind of things that our social workers have just been talking about. And when we were able to really help her work out plans, listen to her, have her identify what she needed, she now keeps her appointments, takes her medication, goes for her transfusions, and rarely is seen in the emergency room. So I think that that's important to me, is to ask all of us to get to know the person that's in the sickle cell crisis. So that's how most of us initially meet sickle cell patients who are suffering from pain, fatigue, and frustration. And I encourage you to get to know the sickle cell patient and to advocate for their best care. And this is one of my favorite pictures. This is us on the sickle cell walk with one of my patients. And I can tell you she's had difficult times in her life, but this is meeting her in a fun place and recognize who she is. And unfortunately, too often, hospital nurses don't get a chance to do that. So I encourage you all to be different about that. Thank you very much.
Thank you so much, Nurse Peg. And what an amazing just row of or round of presenters. And I want to hop right into Q&A because we have some amazing questions in the chat box. Some of them have been answered, but also just open up the floor for people to comment. And is Adiomi still on? Yes, I see you. If we can
Yep, I'm here. I did see one question that wasn't answered by Lynn up towards the beginning. She asked what steps are being taken moving forward for pediatricians to test for the sickle cell trait. So any of our presenters, I think, can take this one.
So, hi, it's Kim Smith Whitley. I can try to address this. One of the things that has been very clear is that individuals with sickle cell trait should be notified after newborn screening. This is something that was very pressing and important to us at Children's Hospital Philadelphia. But unfortunately, when you are told that your child has a genetic trait that shouldn't cause problems, that information doesn't necessarily get stored. So what we're trying to do now is encourage pediatricians to relay the information about sickle cell trait testing in the newborn period and the diagnosis of sickle cell trait to parents, and to have that information follow them across the lifespan. Nurse Renee used to always ask families to put the sickle cell trait status in their vaccine books, so that when the young people go off to college and they have to show proof of their vaccines, it reminds families at that time to have the discussion again about sickle cell trait. However, there is a physician at Nemours who is trying to do a program to really address having electronic health records help individuals with sickle cell trait track their status. But we need more advocacy to encourage individuals in the healthcare profession and families to educate their children about their trait status across the lifespan. Thanks, Adiomi.
No, that's great. I do have another question by Renee. She asks, why don't we have updated population numbers? I read 20 plus years ago, it was 100,000. That can't be true today.
And hi, it's Kim Smith Whitley again. And Renee is exactly spot on. That can't be true today. And there are efforts by the Centers for Disease Control, the CDC, that often will help track different information outside of infections in the US population. And it's going to be important to get the CDC numbers on those living with sickle cell disease in the US, because it is a misnomer. There got to be more individuals living with sickle cell disease in the US now. However, I know that there were some interesting questions about the prevalence of sickle cell disease here in the US. But just to really talk about the scope, even though sickle cell is rare here in the US, it's obviously not rare worldwide. Whereas we have 300,000 individuals born with sickle cell disease annually worldwide. And so we really need to also understand that this is an opportunity to be more global in scope and really try to include worldwide initiatives to educate those on sickle cell disease and find disease-modifying therapies to benefit all.
Thank you, Dr. Kim. It looks like we have some questions from the audience. Walter, I'm going to take you off mute. You can unmute yourself. There you go.
Okay, great. Awesome presentation. I learned a lot. Just want to commend the presenters for their knowledge base, their work that they have done. One thing that I will say that intrigued me was the fact that to find out that sickle cell, I always thought it was more like of a cultural type disease amongst African Americans. But this presentation has really, really educated me, whereas though I find that it's not just a cultural disease. But I do have two questions, one for our physicians, and then the last question is for our social work. The first question I have for our physicians, I heard in the presentation about the challenges that these patients do face, particularly when they're in a crisis, especially if they're new to this disorder, and the challenges that they may have, faced in the ER as they tap into healthcare, and finding that those providers may not be empathetic to their needs or understand their needs. And I wondered, from a educational level, because I think things start at the educational level, are there in-services or emphasis in your opinion or in your experience, where there have been like in-services and emphasis in the medical schools, with the young physicians that are coming out to give them better understanding, to prepare them better as they go into the medical workforce? And then also, when we talk about the ER staff, ER providers, in your experience, have you or participated or seen ongoing in-services for the ER staff, and so that they can be better equipped to deal with individuals with this disorder? So that's my question to the physicians. And then my last question is to the social workers in regards to the mental health. I am a mental health nurse, so it's really big for me. I wonder if there is any studies on the suicide rate, or there is a high suicide rate amongst individuals with sickle cell.
So I can start and answer the first part, and then I'll turn it over to Trudy and Stephanie for the second part. I don't know if Dr. Siani's on, but I also know that Renee and Peg, please chime in. So Walter, thank you for those really insightful questions. I will say that I have found that in-services are definitely needed in hospital settings, both in the ED to educate those who are caring for individuals with sickle cell disease when they come in acutely, as well as in the outpatient setting. And I will also say that the best education starts in training. So the best time to influence upcoming physicians and upcoming nurses and other healthcare professionals is when they're in school. And Crescent Foundation has a unique program in place to educate medical students, where we go out and we work in conjunction, giving them the background on the medical knowledge around sickle cell disease, and then do a panel discussion so that their first impression of sickle cell disease is presented by young adults with sickle cell disease, who can actually provide the best commentary and testimony on the impact of stigma, and when there is lack of cultural considerations and respectful care in these settings. So Tahirah, do you just want to take a moment to speak about your experience with that course, the genetics coursework?
Yes, am I unmuted? Yes. So the program that Dr. Kim is mentioning is our One Gene, One Life program. And we usually do that in conjunction with the first year med students at the University of Pennsylvania. And it's a wonderful program where we get to talk to over 100 first year med students, really humanize what it means to live with sickle cell disease, not just from a patient perspective, but even from caregiver perspectives. This past August, we got to meet with their class through their genetics course. And each year we receive a standing ovation. And it's also one of the ways we tap into getting volunteers to our programs and events through Crescent. But what's interesting with One Gene, One Life, we get these bright-eyed students who are asking brilliant questions about stripping down, stereotypes and biases, and what they can do with coming into medicine to help support patients with sickle cell disease. It's a wonderful program of ours. This year we had 2 caregivers on the panel, and a 3-year-old little boy who was actually cured of sickle cell disease through BMT, bone marrow transplant. And it was a great way to showcase, like these new therapeutic treatments and curative treatments to the class. And they had some great questions for them. And then we also got to have a peer of ours who has struggled with opioid addiction, and really getting to tell his story and how he's blossomed and overcame that obstacle while living with sickle cell disease. And it was another just great way to humanize sickle cell disease, and where you're getting a chance to look at the person and everything they've accomplished, everything they've gone through, but through this program of ours that we thought was really much needed. It's a chance for us to get in front of medical students before they're really burnt out of the medical system with working through so many years. So getting in front of students who are willing to come in with new ideas, greater understanding, is amazing. And what was really interesting about this year, there was a student in the classroom who participated in our program, and I went to a meeting at my local mosque, and she saw me there, and she's like, I remember you, and you did this presentation for my class, my genetics course. And I'm like, oh, you were with Penn? And she's like, yeah, you were amazing. And now she's become like really one of like a champion for sickle cell, and wanting to go into emergency medicine just so she can care for sickle cell patients. So that's how we get to inspire, folks like her. Any other questions? If no more questions, please feel free to put any comments in the chat, or if you have any more questions. Also, before you leave, there is a QR code on your screen. This is our feedback survey. Please take out your phones. You're going to, if you've never done this before, you're going to open up your camera, wave it across the screen over the QR code, and then open up the link, and you'll be able to complete the survey through that link. This is a way that we get great feedback. We know how impactful the program, the session was, how effective it was, and we get to have this data on record so we can improve the program and then also build more funding into the program. And this is how we're able to give up Grubhub certificates and, maybe even have an in-person session where we can do other things with our participants. So please take the survey. If it's 33 people on, we want to have 33 surveys back. And that is it for me. If Abigail, if you have any questions, or Minnie or Walter have any remarks before we close, you are free to have the floor.
I just want to say thank you. Again, I cannot thank you enough. This was so much information and things that I myself did not know. Of the support, the amount of support that's out there for individuals dealing with sickle cell. And my heart is warm, and I'm so happy that we did this presentation, and I know where to turn if I need it, if I need the help. All of the presenters were absolutely amazing. It was very, very well organized, and I just can't thank you enough. And I look forward to us being able to do this again in person or on Zoom, however you will, partner with us again. We're willing to do that. So, and I'm happy for those that were here, and I hope that they learned and got some information that's useful to them. And if not, maybe not for them, but they can share it with somebody else. So again, I say thank you to all the presenters and Tahirah, and everyone just have a great night.
I'm sorry, I'm just going to answer Walter's question really quickly. I apologize. So, I mean, just to circle back, I don't know if there's like any concrete information centered on like suicide in patients with sickle cell disease. I could just go based off of my encounters and discussions with patients. Many of them deny feeling that way and wanting to harm themselves. Most of the time, they really, like it was mentioned earlier, they're very resilient and they're very aware. And, from the time they're, told that they have it, they go through those transitions of learning and being adherent and managing it. And if there are, certain mental health issues like such as depression, like maybe depression is a common theme that we may see. And again, we do our best by trying to get ahead of that by connecting them to like appropriate mental health resources. But as far as suicide in my professional experiences, I haven't really received a lot where patients are expressing suicidal ideation.
And I would just piggyback and say it's been extremely important for our teams to have psychologists on site, who can assess for this on site, and also resources that are that can call to tie and help families move through and patients move through these feelings. So I think that it speaks to why it's important for individuals to be followed in comprehensive spaces. Just so that they have access to more from people who are attuned to what their needs may be.
I just want to just say that thank you again. I'm the vice president for our organization, and I just want to thank you all for just your professionalism, just your again, like I said, your knowledge base. You made me aware of some things, and as a nurse, particularly mental health, and also as a professor, I'm going to be tapping into you all because I would like to kind of like bring this into our nursing program because I think it's important to educate our young nurses coming up as well too, so they'll be able to have the equip, because I think this is very important. So I want to thank you all, and we are looking forward to doing more of this. Thank you.
Definitely, Walter. We look forward to continuing the partnership, and for your class of young nurses, you can always reach out to us, and we can bring the 1G1 Life program to them. Do we have any more questions?
I just wanted to know also, and you can let me know later, but I want to know, is it possible to have a copy of this presentation?
Yes, so the presentation has been recorded, and as soon as we edit it out, and we'll also send the slides from the presenters, we'll get it out to all of the participants tonight.
Okay.
And I just want to give a quick shout out to one of my co-founders. She's on tonight, Ediomi Otaglowry. She's our chief of marketing and communications. And she's on. Ed, do you have any words?
No, this was fantastic. I would just encourage everyone to, at the end of the survey, click to join our mailing list, because that's where you stay informed about what's going on, get the copy of tonight's presentation and the slides that go along with that. So thank you so much. We look forward to doing this again.
And because in light of it being September and it's Sickle Cell Awareness Month, if you want to do any donations, to our organization, you can always head over to our website. The link can be put in the chat, and you can donate to any one of our programs or just make a general donation for Sickle Cell Awareness Month. Thanks, everyone. Go ahead.
Minnie, were you trying to say something? She's muted, but she can't, I guess.
Oh, I can unmute her. Let me
Okay.
go to Minnie. Wait. There you go. You're
Tahirah. I just wanted to say how grateful we are as minority nurse educators. And I have to share with you, when we started talking about this, and we knew that September was Sickle Cell Awareness Month, we determined that we wanted to help our community be more aware about sickle cell and learn more ourselves. But I have to tell you, Tahirah, that when we contacted you initially, we had no idea where to go. And you have really been a blessing in the presenters, and we're more informed. And I'm sure that our president will agree that we might want to be on your calendar for September of next year. Thank you so much.
Thank you, Minnie. Thank you for reaching out. And thank you to Chad Thomas for the connection. Because if it wasn't for Chad, we wouldn't have been able to link up. So Chad, if you're still on, thank you. And thank you for all of your support to the sickle cell community. And I'm going to wrap up and let you all go. So thank you to our presenters. Thank you to all the participants. Thank you if you filled out our survey and gave us some great feedback. We look forward to always reading those over. So remember, if you want to take a screenshot to stay connected of this page, then you can. I think there's some links in the chat. And we look forward to doing this with you all again. So have a good night, everyone.
Thank you. Have a good night.
Thank you.
Thank you. Good night, everyone.
Good night.